Okay, there is pericardial effusion present. Conventionally, whenever there is pericardial effusion with hypertrophic cardiomyopathy, cardiac amyloidosis should become the first diagnosis. However, pericardial effusion does occur in hypertrophic cardiomyopathy. Various series have shown 4 to 10% cases of hypertrophic cardiomyopathy have pericardial effusion. You can also have pericardial effusion in other infiltrated disorders. We would discuss that issue. Okay, so here is a study saying that 4% of the hypertrophic cardiomyopathy patients have pericardial effusion, 50% cardiac amyloidosis, and mostly, of course, in hypertrophic cardiomyopathy or cardiac amyloidosis, the cause is pulmonary hypertension, RV pressure overload, and that is what exactly is there in this particular patient. So pathogenesis of pericardial effusion is impaired resorption of or drainage of the pericardial fluid due to elevated right atrial pressure, and that is little surprising because the inferior vena cava is not dilated in our case, but this is the main mechanism. The other mechanism, direct infiltration of pericardium. We'll also come to that issue as we go forward. Now we focus on the right ventricle. You see the ace of spade appearance of the right ventricle. Right ventricle shows free wall hypertrophy, septal hypertrophy, and apical hypertrophy. In this patient where the contrast has been given, the studies have been conducted by my colleague Dr. Madhu Shukla. I had no role to play in that. Beautiful pictures, and you see that there is actually ace of spade appearance of the right ventricle, and you would say, okay, that is biventricular hypertrophic cardiomyopathy, right, so far? Now you can see the septum, the distal septum is significantly thickened, and of course ace of spade appearance on the right side. You again see the left ventricular ejection fraction 64%. But since there was a non-Q, myocardial infarction, evolved anterior wall myocardial infarction, ECG, a coronary angiogram was done which only showed some plaquing. Look at the ECG shown at the top. Try to compare that with an angiogram. The angiogram shows normal left anterior descending artery, nearly normal right coronary artery, and circumflex artery. Okay. In case you haven't seen the pictures better, here are the pictures. So that is not myocardial infarction. Most likely, at least not myocardial infarction because of obstructive coronary artery disease. Okay, we do a CT. Why should we do a CT in this particular patient? To get more information about that so-called hypertrophic cardiomyopathy where pericardium is also involved. Now keep looking at left atrium is enlarged. You have left ventricle hypertrophy, and the wall thickness or the Hounsfield unit of the muscle mass is absolutely uniform. Muscle mass normally has about 40 Hounsfield unit, and the blood has also 40. So if you look, the blood and the material has absolutely similar Hounsfield unit. Of course, the iodinated contrast has about 250, 300. Is Christopher here? Yeah, he's there. We will ask you to comment on all that stuff later on. Oh, here is the coronal view of the same patient. We are showing you in enlarged left atrium, the left ventricle hypertrophy. You can look at asymmetric septal hypertrophy. The coronaries are normal. And you will see that this mass, this hypertrophy actually has a very uniform Hounsfield units, about 40, 50, 40, 50 all around. There is pericardial effusion. You can see the pericardial effusion. We'll show you a sagittal view quickly. And in the sagittal view also, you would see that the left atrium enlarged, the aorta is coming, and then of course the coronary arteries, and this is the left ventricle outflow tract coming, and left ventricle. Then you see the left ventricle in long and then short axis view and left ventricle hypertrophy. You do also see some pericardial fat. That yellow is pericardial fat at the top, at the bottom of course the pericardial effusion. The fat has a very negative Hounsfield units, more like -50 to -100, so it looks damn absolutely black. While the pericardial effusion has more like 0, 10, 20, so it looks lesser than the myocardium, so you have pericardial effusion. Okay, here is the cine MRI images of the same patient. Iso-intense myocardium, left ventricle hypertrophy. You also see asymmetric septal hypertrophy. And the last picture of perfusion. Perfusion is normal, but you do have thickening of the walls and of course the left ventricle hypertrophy. Good LV function. If you see the two-chamber cine, you would say yes, the ejection fraction looks like 64%. And of course, both atria are enlarged, which are suggestive of HFpEF. So iso-intense signals in whole of myocardium. You would think that all is one whole myocardium is one stuff. But look further. Short axis view, you have of course hypertrophied pap muscle, regional right ventricle hypertrophy, asymmetric septal hypertrophy, and of course some pericardial fat here and there. But that is a cat out of the bag. We did it. This is a standard T2 weighted turbospin echo, and it does show you slightly increased signal intensity. But here you, for some reasons, this we can skip this thing. Let us see if we have some frozen pictures. Some funny thing is happening, but anyhow, this is a T2 weighted images. Okay, look at the left image. Markedly increased T2 values, thickened right ventricle anterior wall, thickened septum, thickened anterior wall of the left ventricle, and you see that the intensity of look at the degree of edema or inflammation, water content in the right ventricle myocardium and left ventricle. That is very unlike amyloidosis. It's not hypertrophic cardiomyopathy. So the myocardium is hyper-intense on star imaging, and this is perfusion imaging. This we have already discussed that part, and this is of course the Smoley sequence for T1, and you would see that T1 values are markedly increased. They are more than 1400 millisecond, but there is spared subendocardial, ruling out amyloidosis. If you look at that rim, black rim tells you that it is reverse of what you see in amyloidosis. So you understand this is not amyloidosis. And this cannot be hypertrophic cardiomyopathy also. Because there is so much of T2 values, and you don't get this kind of T1 values in hypertrophic cardiomyopathy. So we went back actually, and we thought that this was probably lymphomatous invasion of RV and free wall and apex. Housefield units were similar to myocardium, well vascularized. And we decided to look for lymph nodes more, and we were lucky to find some lymph node just above the clavicle. Repeat lymph node biopsy showed non-Hodgkin's lymphoma. 6 cycles of combination chemotherapy with cyclophosphamide, doxorubicin, vincristine, and prednisolone given along with 6 doses of rituximab given every 21 days. So this was a case of diffuse infiltration of lymphoma of the myocardium mimicking clinical hypertrophic cardiomyopathy. What gave us the clue? What should have been the clue? Looking at the pericardium. So when you say detailed echo, those yellow arrows are showing you the pericardium. Pericardium is thickened. Pericardium is thickened, and you do see pericardial effusion. Pericardial effusion should always raise suspicion. The other thing, look at those nodules in the pericardium, they're marked by arrows, and also the right atrial free wall. If we were careful enough, right from the beginning, we would have got the answer. Okay? So, this is of course a metastatic lymphoma. The pericardium is the most common site involved in 41%, and right-sided cardiac chambers involved in 35% cases. We will skip that theoretical discussion, we had enough. But the functional biochemical abnormality may occur earlier due to cardiotoxicity. That BNP, that troponin actually should have told us that this could be amyloid, but this could be something like amyloid infiltrating the myocardium. So we could discuss all that theoretical stuff, but I think I will skip it. And I just say these were the these echo features completely normalized in this patient after chemotherapy. And the repeat echo was performed by my son, but he never gave me the pictures. So I don't have the pictures. I haven't seen the echo myself. But the head of the department of cardiology of the other hospital, under whose the patient was, he said, completely normalized echo. So I got to believe him. Thank you very much.